So we're just talking about birth outside the hospital. And the one thing about birth outside the hospital, it's by definition generally precipitate, and that means that the labour has lasted, less than 4 hours. What I was saying this morning is that for many paramedics, the fear of attending a child being born is worse than the fear of attending an adult arresting, which is frightening that I suppose that is the case. Now, the majority of women that deliver in the community unexpectedly or unplanned are multiparous patients. So 97% of women that are born, or babies that are born outside of the hospital, are born to women who've had babies already. Now, even in a very interventional setting, 98% of those women will have perfectly normal deliveries. And actually you'd nearly need to, intervene to stop them having a perfectly normal delivery. So when you, as a paramedic or an EMT, is called to a birth, what you've got to think is this child is going to be born despite me. And what you've got to do is make a very frightening experience as relaxed and as managed as possible. So when a woman goes in labour, there's 2 phases of labour. There's a latent phase and the active phase. When you're generally called, you'll be called in the active phase. And during that time period, a woman is going often from 4 centimetres to fully quite quickly. And what she'll often do is her body will panic. And this is a natural response to progress. It's not that there's anything wrong with her, but it's her normal response to it. And when she gets like that, then you know that she's probably coming up to full dilatation. Often at that point what happens is there's a little bit of a sus or a relax in the situation, and then she feels this overwhelming sense to bear down. Now, from somebody who's in attendance, first responder, an EMT, I suppose the thing to do is to set it up depending on whether she's at home or whether she's in the ambulance. What do you need? You need to have warm blankets for the baby. But from mum's point of view, what you just need to do is relax her, tell her she's going to be fine and that her baby's going to be fine. What will happen then is she'll feel an overwhelming need to push, and that child is going to come out. And for your average woman who's had babies before, she'll push that child out in 15 minutes or so. So it's a very short time period, and for many it's only 2 or 3. Now, in the hospital setting, we'll often do coach pushing, so we wouldn't recommend doing that in an out of hospital setting, just to let the woman do what she wants. I mean, as I said, you can almost not stop her birthing. Now, often the most frightening thing for people in an out of hospital setting is when a woman starts to crown. So when the baby comes up, so the baby rises up and you can see the head. Now, what often happens at that point is the mum starts to scream, and this puts the fear of God into everyone. But actually, that screaming is totally physiologically, because if you think about it, if you're screaming, you can't push. And what happens at that point is just when baby's sitting on the perineum, and what it allows the baby to do is come up naturally, very gently, and reduces the chances of mum having a tear. So that's actually totally normal. And I always tell my mums, scream away. I said, you're just protecting yourself. And that's what you should do as well in the community. Just tell her to scream away and explain to her why she's screaming. Now, often if she's at home or if she's out of an ambulance, she might be pushing, for example, in standing position or a squatting position, generally either in a forward position or a left lateral position, or good positions for mum to deliver, so with the crowning element, because it protects her bottom a little bit as well. So you want to try and reduce the tears. There is, if you just place a kind of a warm compress or just a little bit of pressure in the perineum just as baby's coming, you can sometimes control the delivery of the head to prevent a tear as well. But you've got to be very, conscious that a woman could be very anxious, and maybe that whole touch would be very traumatic for her, and it's not the end of the world if you don't do that. So it's not, there's evidence for and against. So yes, it would be lovely to do it if you're confident with it, but it absolutely wouldn't be necessary. And you've got to think that this is a traumatic experience for the mom and to try and reduce that. When the baby's head delivers, I suppose the one thing you can do sometimes is just make sure the cord isn't too tight, and if it's there, you can just loop it around baby's head and allow it to relax. And then hopefully what you'd hope is with her next push is the baby will slip out, and then what you just do is you dry the baby and pop the baby up in mum's chest. Now, the one thing that people are often worried about is the delivery of the placenta. Now, the placental delivery can take 20 minutes, half an hour under normal circumstances. So there should be no drama or, nobody should be pulling on the cord to try and deliver it. There's no great hurry in cutting the cord, for example. So the evidence from the WHO would be that we should do delayed cord clamping, because what that does is it improves baby's hemoglobin. So before people were rushing in to cut the cord, there's no need to do that. Dry the baby, drop the baby up on mum's chest and allow things to happen naturally. if the placenta separates, the actual flow in the cord will have stopped before that. So there's no danger to the baby bleeding out backwards or anything. So there's no drama. If you'd like to cut it, fine, but I wouldn't be rushing. Now, the worst thing you can do is start pulling on the placenta when it hasn't separated. So I would recommend an entirely hands-off approach. What you do is you look for the 3 signs of placental separation, which is a fresh bleed, a lengthening of the cord, and a rise of the mum's tummy. And that just shows the uterus is separating. And what will happen is she'll feel a new urge to push, and she'll push down and it'll deliver. And that's birth.
That's
so
fantastic.
All
Right.
very straightforward.
You've taken all the voodoo away.
And I said, for the most part, it's not that you are delivering the baby, it's that you're supporting the mother while she delivers her own baby.
Yeah, I think that was a very important point that you brought out, was that hold the patient's hand and reassure her, and that naturally she will do instinctive things that will support the safe delivery of the baby.
Yeah, I mean, she's set up to deliver. You know, I mean, she's set up to birth naturally, you know, and what you need is, she needs support, and that's psychological. Her partner needs support. He's often beyond terrified, you know, so you need to support them, and it will all happen despite you. But what you can do is take the trauma out of it for the patient and make it an experience that she won't, you know, worry about for the rest of her life. I mean, that was, I think, when I was a very junior doctor, I remember thinking, hey, you delivered really quickly, fantastic. But it was actually when I saw those mothers afterwards, they were completely traumatised. Can imagine you've been planning this birth for 9 months, and it's a back road, you know, and it's raining, and suddenly you realise that you're going to deliver your baby. It must be the most traumatic thing, you know.
So bringing an air of calm to the chaos.
Totally, absolutely. And I think that's probably your major role, is to relax the situation.